Visit licensuraexams.com and try our samples completely free of charge.
Welcome, you wonderful therapists, to the Licensure Exam Podcast. I'm Dr. Linton Hutchinson, and I'm joined today by my colleague, Stacy Frost. Today, we're exploring premenstrual dysphoric disorder, or PMD, a condition you'll need to understand just in case it shows up on your licensing exam.
PMDD is frequently misunderstood and misdiagnosed. Let's distinguish it from other conditions and understand its unique characteristics. Are you sure that's a diagnosis in the DSM, Linton?
It sure is, Stacy. And if all you therapists out there remember anything about this podcast, remember that PMDD is a severe form of premenstrual syndrome that significantly disrupts daily functioning. Let me say that again, significantly disrupts daily functioning. The symptoms emerge during the luteal phase, which occurs after ovulation and before menstruation begins. What makes PMDD distinct is the intensity of emotional and physical symptoms that can severely impact a person's quality of life.
And the emotional symptoms include severe depression, anxiety, and marked irritability. Women often report feeling completely overwhelmed by these symptoms, leading to difficulties maintaining relationships and meeting work obligations. The cyclical nature of these symptoms, with marked improvement during or shortly after menstruation, creates a unique pattern that helps distinguish PMDD from other mood disorders.
The severity of symptoms can be so intense that many women find themselves withdrawing from social activities and struggling with basic daily tasks. The anticipation of these recurring symptoms can create additional anxiety, leading to a cycle of distress that affects multiple areas of life. The DSM outlines specific criteria for diagnosing PMDD. To meet the diagnosis, at least 5 symptoms must be present in the final week before menses, start improving within a few days after onset, and become minimal or absent in the week post-menses. These symptoms must occur in the majority of menstrual cycles.
The criteria specify that one or more symptoms must include marked affective lability, irritability or anger, depressed mood, anxiety, or tension. Additional symptoms might include decreased interest in usual activities, difficulty concentrating, fatigue, appetite changes, sleep problems, feeling overwhelmed, and physical symptoms like breast tenderness or bloating.
It's important to note that these symptoms must cause significant distress or interference with work, school, usual social activities, or relationships. The disturbance shouldn't merely exacerbate another disorder's symptoms, and symptoms must be confirmed prospectively during at least 2 symptomatic cycles. Understanding the development and course of PMDD is essential for accurate diagnosis and treatment planning. While PMDD typically emerges after puberty, symptoms often become more pronounced as women progress through their reproductive years, with peak incidence occurring in the late 20s to early 30s.
The cyclical nature of PMDD is a defining characteristic. Symptoms gradually increase during the luteal phase, peak before menstruation, and then rapidly improve when menstruation begins. This pattern can persist for many years, potentially until menopause, when hormonal fluctuations cease.
An interesting aspect of the course is that symptoms typically abate during pregnancy, but tend to return after delivery. The severity can vary over time, influenced by factors such as stress, lifestyle changes, and underlying health conditions. Some women experience progressive worsening with age, while others have periods of remission followed by relapses. The associated features of PMDD extend well beyond the core diagnostic criteria. Women often report significant difficulty managing stress and emotional reactivity, which can strain relationships and complicate conflict resolution. Cognitive impairments affecting focus, memory, and decision-making frequently occur during symptomatic phases.
Self-harm and suicidal ideation are serious concerns, particularly during the symptomatic phase. Physical symptoms like migraines and gastrointestinal problems often accompany the condition. The intense discomfort can create a sense of physical vulnerability and lead to social isolation.
Feelings of shame and guilt about symptom severity are common, potentially complicating the clinical picture and treatment engagement. The impact on professional life can be substantial, with many women reporting decreased productivity and challenges maintaining stable employment during symptomatic periods.
PMDD frequently co-occurs with other psychiatric conditions, making accurate diagnosis and treatment planning more complex. Mood disorders, particularly major depressive disorder and bipolar disorder, are common comorbidities. The cyclical nature of PMDD can sometimes mirror bipolar disorder's presentation, requiring careful differential diagnosis.
Anxiety disorders, including generalized anxiety disorder, panic disorder, and social anxiety disorder, often accompany PMDD. The prevalence of borderline personality disorder is also increased in women with PMDD, characterized by emotional instability and interpersonal difficulties that can intensify during the premenstrual phase.
Eating disorders, especially binge eating disorder and bulimia nervosa, frequently co-occur with PMDD. Some women may use maladaptive eating behaviors as a way to cope with emotional distress. Substance use disorders are also more common, as individuals might attempt to self-medicate their symptoms. Evidence-based treatment typically involves a combination of pharmacological and non-pharmacological interventions. Selective serotonin reuptake inhibitors are considered first-line pharmacological treatment. They are effective when taken either continuously or during the luteal phase only.
Hormonal contraceptives have shown effectiveness in stabilizing symptoms by regulating hormonal fluctuations. The continuous use of these medications can help suppress ovulation and reduce symptom severity.
Cognitive behavioral therapy has demonstrated strong outcomes in managing PMDD symptoms. This approach helps identify and challenge negative thought patterns while developing effective coping strategies. Additionally, mindfulness-based interventions and lifestyle modifications, including regular exercise and dietary changes, play significant roles in comprehensive treatment.
A multifaceted approach typically yields the best results when implementing interventions. This includes medication management, psychotherapy, and lifestyle modifications tailored to individual needs. The goal is to address both the physical and emotional aspects of PMDD.
Key therapeutic techniques include cognitive restructuring, which helps identify and challenge negative thought patterns related to PMDD symptoms. This involves examining automatic thoughts about the condition and developing more balanced perspectives.
Behavioral activation strategies help people maintain engagement in daily activities despite symptom-related challenges. These strategies might involve scheduling pleasant activities during vulnerable periods and developing contingency plans for high-stress situations.
Emotional regulation techniques, such as deep breathing exercises and progressive muscle relaxation, provide practical tools for managing intense emotions. These skills become particularly valuable during the luteal phase, when emotional reactivity typically increases. The daily record of severity of problems is a primary assessment tool that tracks symptoms over multiple menstrual cycles. This detailed tracking helps establish the temporal relationship between symptoms and menstrual phases.
The premenstrual symptom screening tool provides standardized measurements of symptom severity, helping differentiate PMDD from other conditions. This tool is handy for initial screening and monitoring treatment progress.
Additional instruments include the Calendar of Premenstrual Experiences, which records both symptom severity and functional impact. The Hamilton Depression Rating Scale and Beck Anxiety Inventory help assess concurrent mood and anxiety symptoms. Let's summarize the key points about PMDD. This condition represents a severe form of premenstrual syndrome with a significant impact on functioning, requiring careful differential diagnosis from other mood disorders.
Accurate diagnosis relies on prospective symptom tracking and careful attention to the timing of symptoms in relation to the menstrual cycle. The presence of significant functional impairment distinguishes PMDD from more common premenstrual symptoms.
Treatment typically combines pharmacological approaches like SSRI with therapeutic interventions such as CBT and lifestyle modifications. This multimodal approach addresses both the biological and psychological aspects of the condition.
Understanding common comorbidities and differential diagnoses is essential for accurate diagnosis and treatment planning. Regular assessment and monitoring help ensure treatment effectiveness and guide necessary adjustments to the treatment plan.
And remember, it's in there.